Hello, my name is Sinead Maguire, and thank you to the Journal of Rheumatology for inviting me to discuss our paper entitled Central Obesity and Axial Spondyloarthritis, the missing link to understanding worse outcomes in women, on behalf of myself and my co-authors. In axial spondyloarthritis, or AxSpa, obesity is known to be associated with higher levels of disease activity and a decreased response to treatment. This is due to secretion of adipocytokines from adipose tissue, which create a state of persistent systemic inflammation. Unfortunately, obesity remains a very commonly encountered comorbidity in patients with AxSpa. Central obesity can be detected by calculation of the waist-to-hip ratio and is known to be associated with an increased risk of cardiovascular death, type 2 diabetes, and premature death. In the general population, this is more commonly encountered in males, but there is limited data on prevalence of central obesity in patients with AxSpa. The aim of this study was to determine, firstly, the prevalence of central obesity in AxSpa and its effects on disease-related outcomes, and secondly, how this differs between sexes. To do this, we extracted data from the Ankylosing Spondylitis Registry of Ireland, or the ASRI, which is a large national registry of patients with AxSpa recruited from all major geographic regions of the country as depicted on the map here. All patients must have been diagnosed with AxSpa by a rheumatologist and meet the 2009 ASAS criteria for AxSpa at the time of enrollment. Physical measurements for all eligible patients were compared on the basis of obesity classification using two commonly used anthropometric measures, the body mass index, or the BMI, and the waist-to-hip ratio, or the WHR. A series of comparison analyses compared patient outcomes on the basis of sex and the presence of central obesity. These variables were then compared as part of a multivariate analysis to assess the impact of these variables on the following patient outcomes. And these are our results. So at the time of data extraction, physical measurements were available for 753 participants enrolled in the ASRI, of which 71.4% were male and 27.6% were female. In total, 29.6% of patients were obese based on BMI, while 41.2% were obese as per the waist-to-hip ratio. I want to draw your attention to the average BMI scores circled in red on the table here on your screen. And what you'll notice is that there was no significant difference between mean BMI between men and women in our AxSpa cohort. However, if you look down at the waist-to-hip ratio, again circled in red on your screen, males were found to have a significantly higher waist-to-hip ratio as compared to females. We then looked at this in more detail. We then compared weight classification using these two anthropometric measures, and you'll see on your screen here, males are depicted in blue, females are in green, and if we look at the results for BMI, there's no significant difference between males and females for those that are classified as obese, but if we look at the results for waist-to-hip ratio at the top of your screen, there's a significantly higher prevalence of females with central obesity as compared to males with central obesity. We then went on to compare the patient outcome scores for patients on the basis of presence of central obesity and found that those who were centrally obese recorded higher average patient outcome scores compared to those without central obesity. So we've now established that women have a higher prevalence of central obesity, and patients with central obesity tend to have worse outcome scores. So to look at this in more detail, we carried out a multivariate analysis to see if there was an interaction between sex and the presence of central obesity. And although we did not detect an interaction effect, both of the main effect of both sex and central obesity when assessed individually did have a significant effect on patient outcomes. A follow-up univariate analysis examined the effect of central obesity on numerous patient outcome scores and found that this effect was significant for ASQAL, BASV, and HAC, with a trend towards a non-significant effect for BASDI as well. The results of our analysis were novel in a few different aspects. Firstly, in that it demonstrated A high prevalence of central obesity in patients with AXPA. Secondly, we also demonstrated the detrimental effects of central obesity on patient outcomes. And the reason these results are important is that central obesity is a potentially modifiable risk factor. And once identified, this can be targeted with multidisciplinary intervention and support to improve patient outcomes. One of the most surprising findings from our analysis was the significantly higher prevalence of central obesity in women with AXPA compared to men. And this has huge implication in terms of trying to improve control of disease activity in AXPA and even improving treatment response for women with AXPA. The waist to hip ratio offers an opportunity to improve identification and detection of obesity in all patients with AXPA. And this is important to consider, especially in women, because BMI, which is currently used to detect obesity, was developed primarily for use in males and has previously been demonstrated to perform quite poorly in certain female populations. By comparison, the waist to hip ratio is a simple yet effective tool to screen for central obesity in AXPA. And this cannot be emphasized enough. Prompt identification is vital to improving, to creating a window of opportunity for intervention for these patients. In conclusion, central obesity is highly prevalent in AXPA, and especially so for women. It is significantly associated with worse patient outcomes, and we should be considering using the waist to hip ratio when performing screening for obesity in patients with AXPA. Last but most importantly, it's important to remember that central obesity is a modifiable state, and prompt identification can create a window of opportunity to allow for intervention with a multidisciplinary approach. Thank you.